My name's Robin Hudson. I'm a GP in Corbridge and I'm a Joint Clinical Director for the Northumberland Vanguard programme. So without any further ado, I'd like to welcome again Professor Chris Ham to come and speak to us.
My own cards on the table. I do think ACOs or ACO type organisations and systems could play a really important part. And they are, as I've said already, just different ways of describing the same thing. How can we move from fragmented care to integrated care? So primary care and secondary care, health and social care, physical and mental health services working together rather than working separately. Bottom up, not top down, to get organisations and services working together in the way that I believe lies behind the plans for ACOs here and elsewhere. The secret is it's more sociological than technological. The relationships between the clinicians in the different organisations and the leaders of those organisations. Do they trust each other? Are they willing to collaborate? Are they willing to give up some of their sovereignty and independence for the greater good of the population they're trying to serve?
And I think we've got a good track record relationally, and I think personally I feel excited by that, though it is going to be a huge task and hugely daunting, and it's not just about one leader or two leaders, it's about all of us. Actually, maybe it's all of us understanding we have a leadership responsibility to do that work.
The principle of an ACO is a single budget to cover the whole of the population's health needs. You spend it once, you can't spend it twice. So the provider partners need to have a prior understanding of how they're going to deal with overperformance in one part of the system.
Loss of autonomy of primary care. We are all our own bosses at the moment, and I think the worry is that we are going to potentially lose that. We're also used to having some say in the budget, and it feels like a little bit, especially after today, it feels like that may be something that we don't have quite so much say in now. I think it's unknown. I think that's the biggest problem, is it's not been done before like this, especially at this scale, and I think we just don't know yet, although something needs to change.
If you only come together in a provider partnership once a month or once a quarter, you're doomed to fail. You need to be looking in each other's eyes over the dinner table or over the committee table, whichever of these appropriate relationships you want to think about, in a loving, purposeful way. This can't be a one-night stand. There's got to be a sense in which we're all in this together for the longer term. It's worth making that commitment to frequent personal contact, for me getting to know you. So when we walk out of the room, do I really trust you? Can we work together on these issues? Do I believe what you say, or are you just saying it and then you'll go off and do something else?
I think the ACO itself is just the start, and actually you need to have the structure in place to then actually get the relationships and get everything else working. So I think that seeing it as the end point actually rather than actually the start of the next journey is really important. And I think if people think that the ACO will miraculously achieve everything, that would be wrong. So I think people need to see that this is the start of a different way of working and also a different way of thinking in terms of how we deal with population healthcare.
The concern I have is that individual practices will lose their identity, will lose their independence and be told what to do.
If you move from fragmented care to integrated care, it helps you to reduce variation, to reduce waste, to reduce inefficiency. To be concrete, it helps you to reduce the number of people in the local hospitals who are clinically ready to go home, but we can't get them home because we don't have the investment in social care, community, general practice, and so on. Every day that patient is in a hospital bed is a waste of public resources that can be much better spent if we were able to invest those resources in the community-based alternatives. So it's for people locally in leadership roles, in clinical roles, to come together and figure out what's best here based on good leadership, a single budget, delivering improved outcomes for the local population, and with all the management support that will be required to support GPs and their teams to play a full and effective part.